Hi, everybody. Thanks so much for joining this special complimentary roundtable discussion with Fred Ochieng. We are here to discuss Lwala, which is based in Kenya. And, we recently had an opportunity to sit down with Ash Rogers. And in that podcast, we learned a lot about the current reality of Lwala, how it operates. And it was a great introduction to all of Lwala's clinical achievements and their programmatic chops. But, one thing that was interesting is that Ash mentioned that she came to work with Lwala because of two Kenyan brothers that founded the organization. And at the time, I brushed that off as, yeah, that's fantastic. That makes sense. But I didn't really dig further into that story. Then, recently, I was on a trip visiting Zami La Sante in Haiti, and I met a cardiology fellow at Harvard who is one of those Kenyan brothers. Fred here sitting next to me, and I thought it would be a wonderful opportunity to sit down with Fred and to get a little bit more of the story of how Lwala came to be and how it currently operates. Freddie, thanks so much for coming by and speaking to me.
Thank you, Dan. Hello, everybody, or Jambo, as we say in Swahili. So my name is Fred Ochieng. I grew up in a small rural village in western Kenya. The village is called Lwala. I'm the third born in a family of 6 kids. Life in Lwala was quite amazing. It's a place where you would just wander off to your neighbor if your mother prepared some food that you didn't really like. And so you go off to your neighbor and eat their sweet potatoes or eat their fish. And, a strong sense of community. People took care of one another. But also, growing up in this small rural village in western Kenya, we did not have access to healthcare. No running water, no electricity. So I remember when we were growing up and we would get sick with malaria, the same little shop where you would buy soap, buy sugar is the same place where you could buy painkillers and such kinds of medications. And so when my brother and I would get sick with malaria and we couldn't swallow the chloroquine pills, then my dad would ask my mother to boil the needles and the syringe and get ready for a chloroquine injection. So, we got used to, that's a kind of a life growing up in a place that did not have access to healthcare. But even during our teen years, we remember the tragic consequences of growing up in a place that did not have access to healthcare. One of my neighbors, her name is Ben, his mother was in labor. Now, typically the women in the village would go deliver their babies at the traditional birth attendant's place, and she developed complications. So the villagers put her in a wheelbarrow that they borrowed from the local primary school teacher, tried to walk her 6 miles of an unpaved road to try to get public transportation. So they would take her to the nearest hospital more than 10 miles away. Unfortunately, she died, she bled and did not make it. So the following day, we woke up to the village wailing, and we knew, unfortunately, that Ben had lost his mother. So, these were some of the tragic consequences growing up in a small village that did not have access to healthcare. Dad was a high school teacher, taught biology, chemistry, and Mom was a middle school teacher. She taught a little bit of everything from English to music to arts and craft. So that's how we grew up in this small village in rural western Kenya.
But ultimately, you left that small village and you ended up now to become a fellow in cardiology at Harvard. So tell us, how exactly did that trajectory go?
Yeah, so really it's with a lot of sacrifice and support from the parents, and if it weren't for their support, we really wouldn't be where we were. They really valued education. So we were 6 kids. My brother and I, Milton, he is just a year and a half older than me. We kind of followed one another in our paths in school. So, my parents would take out loans and ensure that we went to some of the best schools. Around 5th grade is when I went to boarding school. My brother Milton actually went to boarding school when he was just about in 4th grade. And so he went to a really good school, Ndere Boys, and from Ndere Boys, they were performing really well. So he actually qualified to go to one of the top high schools in Kenya. So usually at the end of 8th grade, you sit for a national examination. Then depending on how you do, that will determine what kind of a high school you get to go to. So national schools are the top that pick kind of the top students from each district. Below national schools, then you have the provincial schools, then the district schools. So Milton qualified to go to Alliance High School, which is the oldest high school back in Kenya. And, to go to high school back then, it was probably about $500, which was a whole lot of money for my parents who were supporting 6 kids. But so Milton went to Alliance High School, and I followed him a year later on. And really, it's at Alliance High School that, our eyes were opened to some of the great opportunities outside of Kenya. Alliance High School had 2 exchange programs, one with Brooks High School in Andover, Massachusetts, and the other exchange program was with a school in the UK. So Milton actually got to participate in the Brooks exchange program. So he was able to come to the US during high school. So 2 kids from my high school would come to school in the US for a semester, and then 2 kids from Brooks would come to Alliance also for a semester. So it's when he was here that he actually got to see MIT, see Harvard, so get an idea of what school was like outside of Kenya. Because really at the end of high school, we had both been admitted to Nairobi School of Medicine. But, we sat for both the national examination at the end of 12th grade, and then also sat for our ACTs, test of English as a foreign language, and applied for colleges in the US. And so we were both fortunate to get full scholarships to go to Dartmouth College. And, Milton went first.
In New Hampshire.
In New Hampshire. But before he could make it to New Hampshire, our parents were really low on funds. So there's this thing called a Harambee, which is a kind of a pooling together of resources. So they, the school, the locals, one of my parents' really good friends, the same school teacher whose wheelbarrow the villagers had borrowed to try send Ben's mother down the unpaved road. So he's the same guy that my parents requested to be in charge of the fundraising event. So, you invite all your friends to come to the fundraising event, and they raised more than $900 for Milton's plane ticket to come to the U.S. So, people would sell their chickens, sell their goats, and that's how they raised money to send one of their sons to the U.S. And, they just told him, make sure you come back. So that was kind of the parting gift or request that they had for Milton.
And you followed?
So I followed him. I never left Kenya. So I really didn't have an idea of where I was going, except for pictures that Milton would send me from Dartmouth College, playing soccer in front of the library, and it looked like it was a whole lot of fun. So I was sold, and I was fortunate they gave me also a full tuition scholarship, which is incredible. So just those opportunities that our parents afforded us. So we really owed a lot to our community, our parents. So those were some of the things that we kept in mind as we were coming to study in the US.
So that's extraordinary, with really strong investments from both your community and then also the institutions that ultimately would receive you. You guys were catapulted now into this world-class education. It sounds like a lot of responsibility. It's both an opportunity, but it sounds like quite a bit of responsibility. But it seems that you've done quite a bit with that. What was the decision to turn all of this privilege into an organization that would go back to Kenya to serve the people who got you there?
Yeah. I think, so growing up, both Milton and I were interested in the sciences and medicine particularly. So my dad was a chemistry teacher, biology also, in high school. And so I remember during high school when I would come back home and I'm trying to memorize the elements in the periodic table. And he would bring home some chemicals and we would make chlorine gas out in the open. So I thought, science is kind of a cool thing, but then also just
Sounds dangerous.
yeah, a little dangerous, but fun for a teenager.
Yeah.
But so we knew that we were interested in medicine, and knowing that people back home did not have access to medical care. So both Milton and I thought about becoming doctors one day. But it really wasn't until we were in college that some events back home kind of threw us into a crisis mode that made us think that it really wasn't going to be in our timeline of wait until one day we become doctors to go help take care of the people back home. So during, late in high school and towards the beginning of college, we started noticing that back home there was a mysterious illness where young men and women or young adults would suddenly become sick, and they would just get thin, grow weak, and would die eventually. Not many people understood what was going on. So now in our culture, there's something called chira. Chira is you do something which is taboo. So say, for example, you went and plowed the fields and planted crops before your parents did. So that's a big taboo. So people had all sorts of interesting explanations for why it is that so-and-so was thinning away. They all blamed it on chira. We would see homes where people would close their houses and have to take the kids to go live with the grandparents.
Yeah.
Just because young adults were dying in really incredible numbers. So we'd seen this happening, and then when we were in college, we started seeing that our parents were also getting ill. Interestingly, in our community, so we are from the Luo tribe. Luo is one of the 5 largest tribes in Kenya. Interestingly, the Luo community, many people actually, men would marry many wives, and my dad happened to be one of those people. It was very common. His brothers also married multiple wives. So my stepmom, actually, way back before I went to high school, she became sick, and she eventually passed away. We didn't really know what she died of. But so much later on, when we were in college, and then, my mom is the one who got sick first. And so she had a lot of coughing. She started becoming thin. Later on, they found that she had HIV and was in late-stage AIDS. So at that point, the fact that there was no access to healthcare facility home, she had to be hospitalized more than 20 miles away from home. And at that point, weak healthcare systems, people would have to travel about half a day to be able to get the antiretrovirals. So the medications to treat HIV. And they had to ensure that they wouldn't give you a whole lot of medications. To ensure compliance, they had to make sure they give you a few meds, you travel again, go back. So, there would be half a day of traveling. And when people get so sick, then it became more of a challenge. So, my siblings back home had to drop out of school to go help take care of my sick parents. Both of my sisters dropped out of school. One of my sisters was studying to become a pharmacist, so she dropped out. So she was taking care of my mother in the hospital. Our oldest brother had to drop out of teacher training school to go take care of the parents. So, it was just a very tough, emotional time, being away from home and to see that, our siblings had to leave school. But then in spite of, I think she just got started on treatment too late. So anyway, she died junior year in college.
Wow.
And I think it really is at that point that we were hit by a crisis. And so it became an issue of we really didn't have the time or the luxury to wait and see one day we would become physicians to go help take care of people back home. That's when we started talking amongst ourselves. And, my dad was back home. And after my mother's funeral, then we started talking about wouldn't it be nice to build a small clinic in our village? And so then we told our dad to start working with the villagers to put together a committee to think about how much it would cost to build this clinic. And we figured we were in a very rich country. We knew we had friends, so we we just dared to dream that we may involve them in thinking about this clinic, and being how generous and rich this country is, maybe people would dream together with us to try build a clinic to help people back home. Yeah.
And you had that extraordinary opportunity because you had one foot in the United States, one foot still back in Kenya. But there's something that I think is worthwhile to highlight is that Lwala, as we know from the conversation with Ash, has achieved extraordinary clinical outcomes. Mm-hmm. And she spoke quite a bit about how maternal mortality has been improved, specifically because women are giving birth with attended birth in facilities. But one thing that really resonated with me, and I think probably a lot of our listeners, is that when they looked at the women who were now coming to give birth, too many of them were teen pregnancies. And so the team thought, well, what can we do to start tackling that? There was this sort of upstream effect, or this upstream factor focus that the team wanted to focus on. And I think that Lwala, having been started within the community, but then also invigorated by the community, there's an opportunity to start thinking more holistically. So I was just wondering, get your thoughts a little bit about what are the pros of approaching health and healthcare delivery with this larger, more holistic approach?
I think it's incredible to see how, when you start thinking about various health issues, how intricately they get intertwined with some of the other things that you wouldn't traditionally think about. Back home, it was impressive. Even when we went back home and recruited the villagers, our soccer friends who were going to get sand out of the river when we were beginning construction for groundbreaking of the facility, then quickly you get approached by your friends and people who don't have money to make it to high school, or even if they make it to high school, they're not able to continue their education to go to college. So the fact that poverty is intertwined into a lack of opportunities or access to be able to continue your schooling. And then, so there's education, then health and sanitation. You quickly notice that in many communities where you didn't have people who are, either sensitized or educated to know that they need to have a safe way to dispose of human waste, then that way, people go swimming in the river or they don't use latrines, then diarrheal illnesses and such things. And then you quickly realize also that most of the people in the village are subsistence farmers. So we grow sugarcane, we grow maize or corn, beans, potatoes. So if rains do not come, people live on the edge. So if you don't get a good amount of rainfall, your crops fail, then people don't really have much of income to be able to spend on anything else. So then quickly, I think it was just looking at the needs of the community. You would have people coming by studying to ask for scholarships for education. You have young people who had dreams to have a chicken coop or something like that, and they just needed the initial capital. And then after meeting with people in the community, the stakeholders in the education component, and you realize that many schoolgirls would start dropping out of school at about when they get to 4th grade, because when they start having their menstrual periods, then lack of sanitation products or just not having school uniforms. Back at home, the culture is such that women get married and they have to leave the community. So with limited resources, parents would rather educate the boys because the boys will stay in the community. So that's an assured way of having somebody who will take care of you when you grow older.
Well, the women leave the community because they get married.
They get married. Gotcha. So when you're in this clan, you have to get married to a different clan. So then parents would not have the incentive. If you have limited money, I'd rather take my son to school because he will stay around and he will take care of me if he gets a good job. So we realized that having well-educated women, it's been shown to be such a powerful tool in improving the health of the whole community. So just by providing school uniforms for girls at when they hit fourth grade with the sanitary pads, and then we quickly realized that the girls were staying in school, and then at the end of eighth grade, just to have the opportunity to be able to get scholarships to go to good high schools. Then now, after several years of working with the community, so now we're seeing our numbers are coming where the boys and girls graduating primary school is almost right at par.
Wow.
So I think it's really just being that, there was a village committee. We listened to the people in the community with their requests and their needs, and then just working together with them and bringing them alongside and seeing how best it is that we could support them.
And then a lot of times people will agree with you, but their funding doesn't allow it. So much funding is vertical, let alone for disease, but more specifically for one disease.
Correct.
It's completely only for HIV, only for TB, only for malaria, whatever it might be. So what would you tell the people who might be trying to do this type of holistic approach, but are finding themselves shackled by vertical funding and vertical approaches?
Yeah. It really works best to have the holistic approach, but in the setting of not having, if you have people who are opposed to the idea or who really haven't bought into the fact that a holistic approach to improving healthcare is the best way to go. I think it would be helpful to see examples of where it has worked and see how powerful it can be. Because even for us, just the fact that we were operating for more than 3 years, we did not have electricity. And then just having bad roads, which meant that although we were able to, we'd raised funds to be able to get ambulances, which we could use to refer cases of either mothers who were in distress during labor, refer them to the bigger hospitals. But before we improved our roads, during the heavy rains in April, May, you really would be stuck. So there have been plenty of examples of places where using money that is supposed to, say just for HIV, you quickly realize that people with HIV will actually need a whole lot of support. Anywhere from nutrition to just the treatment which can also be a way of prevention. People with HIV will get malaria and other opportunistic infections. People with HIV will have a need to, psychosocial support. So taking care of all these other things together is going to make sure that you really take great care of the patient as a whole. So then that way, if you're able to use that funding that, principally was meant for HIV care, but if you're able to support those other systems, then that way you really will be able to take great care of the patient if you're able to strengthen and support all these other components.
Our team in Haiti, Zami La Santé, or Partners in Health Haiti, that you and I just went to visit, they had a term for that in Creole called the chol bataille, which was the battle horse. Basically, the use of this vertical funding as a sort of a vessel for then approaching these much broader horizontal care delivery questions and then the social determinants questions. Now, but that question around the community and you guys feeling an acute need to address health and its determinants and a holistic approach, that was really something that came from the community. The community committee is one mechanism to have a strong voice of people in the design and delivery of services. It, however, is not always as easy as that. A lot of times people will create a community committee and find out that it's a lot of trouble and just shut it down quick. What's been your experience around that, and what do you think are some of the components for good community committees or other mechanisms for incorporating the community voice?
It takes a lot of patience. We have had various membership troubles in the committee, lots of politics in the village. So, initially it had to be, you needed to have 2 members from all these little sub-clans, make sure everybody is well represented. And then once the people come in, some people are going to be more effective than others. Some people are more committed. Some people never come to meetings. And then there are those who probably just show up because are they anticipating that there's going to be some money that they get from being in the committee. But typically, you just have to have the patience. Those are the kind of meetings that would last. They could easily have meetings for, more than 6 hours. You pull your hair out. But, you realize what value it is that they bring to you. And then you just have to be patient with them because they have great input and great insights into what's going on in the community. But, aside from having the village committee, I think another crucial time in the process really was when we were thinking about expanding our maternal services. We were at an inflection point where we knew that, more than 75% of mothers delivered their babies with the traditional birth attendants.
Yeah.
So knowing that the skill level in the village, we didn't really have too many people who, our nurses, most of those folks in the healthcare facility had to come from outside the community. So we were faced with an issue whereby most of the women really trusted the traditional birth attendants. So after much discussions, and this is also credit to some of the relationships that our friends from Dartmouth who had been visiting the village, some of the obstetric gynecologists, some of the masters in public health students who'd been visiting, spending some time with the traditional birth attendants, and kind of just building that trust between the healthcare facility and the traditional birth attendants. So we decided to bring them into the healthcare facility and have them be the ones that accompany women during the labor process or even prior to that, and help give advice during the delivery process. And when we got them to join the group of the community, the wider community health workers, we saw something incredible happening, whereby now the traditional birth attendants will tell the women, we are all delivering our babies in this healthcare facility. And seeing numbers going from 25% to greater than 95%, and it's been sustained at about 97%. It's just been an incredible thing to see. And this is really knowing that the community health workers and the traditional birth attendants, they're so well trusted, but they also knew everybody in the village and the wider community, and they could easily reach them, encourage them to come for antenatal visits, and that way, they were able to map out all the pregnant women in the community, which is an incredible thing that, to think about, so that, none of them were left behind. And so really, it's just the power of getting the people in the community excited about a cause and to see how they can take it to the next level. And now everybody is excited to even do more. What can I do for the community? It's just an exciting time in the community to see everybody having that sense of agency.
And I think probably what I'm hearing is that the combination of effective services in the clinic plus the familiar face and voice of the community members that you've incorporated as part of the team, you sort of get a double whammy for the patient. The patient says both, this is something I recognize, but it's also something that I want, that anyone would want, because it's high-quality care. But yet I'll focus again on the challenges, because I think about my own experiences working in Latin America and how difficult it can be when the community and the factions that you were describing, the different clans, the subgroups, religious, ethnic, otherwise, when they clash. You're a seasoned and expert community organizer and physician. Tell us a story, perhaps, about a time when the clash came and what you did to address it. we have to learn from this is like an M&M
Yeah.
conference, right?
Yep. I mean, I think the clash sometimes, I have quite a few stories. One really heartbreaking one to see recently, just a few years ago. It's been incredible to see some of the traditional birth attendants and the community health workers in the facility, just the power of word of mouth. And now, one of the great things that we are working towards is having hopefully a next generation that's free of HIV. So to see the word of mouth, mothers come into the facility, they get their HIV positive, they get their antiretrovirals, they deliver their babies, and during subsequent testing, they are found to be HIV negative. And now that's such a powerful story. And so people say, okay, well, these medications work. And so lots of people are coming in who are HIV positive, and we are seeing about 98% or so of babies being tested as they go into infancy, and they are all HIV negative. But I think stigma is a very tough, can be tough to overcome. I would say we have made such tremendous progress, but I think every now and then something happens that kind of hits you in the stomach, and you look back and say, we still have some work to do. Actually, one of the workers in the healthcare facility in Lwala, he was known to be HIV positive. He could get his medications right there in the healthcare facility, but somehow he just, I don't know exactly what it is, because there were medications in our healthcare facility, there are medications in neighboring facilities even closer to his home where he could have got treatment, but he really shied away and shunned the care that he was being offered. He ended up dying of opportunistic infections. And, he was a young guy in his 30s. And to know that this is somebody in the facility that we could have taken care of and would probably have lived many, many years, to know that stigma, or I'm not sure what else it could be, that prevented him from accessing care in the facility. So that's one example of how much groundwork we still have to cover. The challenge with getting young men or young adult males to get tested and to get treatment. Many of the infections, the new infections of HIV, among young girls. So it's still really much of a disease that's affecting young women. And it looks like it's the young adult males who are probably the ones infecting them. To be able to get them to change their health-seeking behaviors, or to, reach out to them, that's still one area that I think I'm very curious to see what are, kind of the best practices to be able to get them to seek care. Because, we have things for young men who are still in school, and they do participate. We have these activities for them to come be involved. But, the young adult males have been the ones that have been difficult to reach. Thinking about issues of corruption, nowadays in the healthcare facility, we have done a whole lot of work. The leadership in the healthcare facility has been amazing. But those were some of the challenges that crippled us in the beginning. When you have funds coming in and you have people who are either not very well trained and they don't really know how to keep track of funds, and so just losing money that you have worked so hard to bring in to serve the community. So that was a challenge. And one other interesting unintended consequence is sometimes when you are known to be affiliated with your nonprofit organization that's known to be affiliated with the US, you get discriminated against because people know, or they think that you are linked to the US, so you must have a lot of money. So ironically, there have been some times when we go seeking partnerships with some of the local organizations, and they kind of just drag their feet, and kind of behind the scenes you hear this discussion of, it's an American organization or American supported organization. They probably don't need a lot of help from us. And I think there was a little bit of that kind of politics in the beginning when they did not want to connect us to the national electric grid because they believed we had a lot of money and we were going to pay a lot of money to be able to get connected to the electrical grid. So, there are those challenges that you face, even initially with the Ministry of Health when we began. I probably wouldn't blame them too much. For example, when we were just opening the clinic, and we needed to get medical supplies in order to run the healthcare facility. We went to the local Ministry of Health official, and he was supposed to write us a recommendation so that we could get supplies from the Kenya Medical Supply Agency. So the Ministry of Health official said, we need you to show us that you've been operating for at least 6 months, so we see what you're doing before we can write your recommendation. But you can't really operate if you don't have the medications that we are trying to get. So how are we going to be operating for 6 months, but we don't have the medications to be able to operate for 6 months to begin with? So there was that kind of skepticism in the beginning, and maybe I really wouldn't blame them too much because here was a case of 2 Vanderbilt medical students showing up and claiming they want to run a healthcare facility. So they were rather skeptical in the beginning, but it's just you never give up, you never lose hope. So we figured out ways to obtain supplies. It was more expensive that way, but you stick with the goals. So it's slowly with time that we win their trust, and they come and see the kind of work that we are doing. And now the Ministry of Health is really one of our strongest supporters. They help us in terms of supplying medications, vaccinations. So they've become a really strong partner. And actually, now the Ministry of Health is asking us to figure out ways in which we can expand the work that we are doing and some of the positive outcomes we have had in our immediate catchment area of about 30,000 people. How can we replicate this or scale this up to the whole county of Migori, which is, about 1 million people?
Wow.
So it just takes time, it takes persistence, and you don't really give up on those strong partners that you really need for the long run.
And would that scale up being with the Ministry of Health and some of their operations, or do you think it would continue to stay separate?
You mean in terms of would the operations as in to support the various healthcare facilities? Or?
Yeah, exactly.
I think we're still working on the fine details of that.
Yeah.
Our strength really has been in what we do with community health workers and our public health outreach.
Yeah.
But, all of that still relies on having a strong healthcare facility at the base because you have to, the folks have to have
referral
abilities.
Trainings.
Correct.
Supply chain.
Yeah. So it's a little bit tricky. We are already training community health workers in neighboring communities.
Yeah.
But, even in those neighboring communities, we need to raise up the leadership and have folks who are going to be able to advocate for the communities, because in that way they need to engage the partnerships in those areas so that they can also have, if you're going to be referring people to the healthcare facility to deliver the babies, what if there's a complication? So they must also have the infrastructure to be able to support so that you're not driving or changing people's healthcare seeking behaviors, but when they come to seek care, there isn't much that you do offer them. However, when it comes to things like, say, immunization outreach, in our community, our immunization rates are well above 95%. So, that's kind of a low-hanging fruit that, if it's in terms of improving water sanitation, improving immunization coverage, those are things that we could easily do just by involving community health workers and partnering with the Ministry of Health.
Yeah.
But then there are those other interventions that definitely require much stronger infrastructure in the communities.
Well, that's one of the real challenges some organizations start to face when they find themselves at that intersection of growth, which often requires collaboration with the ministry, because the ministry is usually the biggest player in town, but then also the desire to provide holistic, community-centered, community-responsive care, in which you're hearing what the community wants and you're sort of redirecting funding to better address social determinants and improve outcomes. And it's a very interesting and difficult balancing act. You know, I know from my own experiences that some countries where we have worked, this is Partners in Health, the government asked us to come, and it was immediately with the ministry, and then you created outreaches to the community committee and others. There's other places where it started in the community, much like Lwala, and then as it grew and became very successful, people said, we want more of that nationally, and you have to then make a decision, well then what do you cut? And we talked a little bit about this to Ash, but one of the things that I really like about what you're saying, and you said it somewhat in passing, but I think it really captures a lot of the energy of what makes your work so special is you never give up, you never give up hope. You keep searching, and it's that desire to not give up, to always hold on to hope that then says, okay, well, this person with a difficult disease to treat, be it HIV, with some element of non-adherence, because of a variety of different factors, well, what are the other interventions that we could put in? What in the community, what in the family, what in the economic situation can we do to sort of raise this up? Now, you yourself are obviously incredibly well versed in HIV and other diseases common to sub-Saharan Africa, but now you are a cardiologist doing your fellowship here.
Yes.
How do you see your trajectory moving forward as you've now developed these new skills in a new entire arena of medicine, but yet Lwala has incredible needs it continues to address, and then also is positioned to expand?
Yeah. You know, my life is confusing, but exciting. I think we have some incredible opportunities ahead of us. I think it's been fascinating to see how non-communicable diseases are becoming a major burden to the healthcare system in many parts of sub-Saharan Africa. And among these non-communicable diseases, cardiovascular disease is also quite a bit on the rise. So that's a major component of the non-communicable diseases that our healthcare system is getting ready to, or is already burdened by. So I think here I am, with training in internal medicine and pediatrics, and then spicing it up a little bit with cardiology. I think it's actually putting me at a very unique position to think about the health of so many people back in sub-Saharan Africa, where we have a shortage of healthcare providers, and thinking of ways in which we potentially could use, some of the lessons that we have learned in the work that we are doing in places like Lwala, to think of ways in which we could potentially impact non-communicable diseases. So with cardiovascular diseases, thinking about heart failure is a major problem. Thinking about high blood pressure and stroke, probably those would be some of the major things to think about, and as well as congenital heart diseases, as well as valve disease in many parts of sub-Saharan Africa. So thinking about how we can help and strengthen the healthcare systems. We've seen incredible examples, taking lessons from, say, money that various nonprofit organizations like Partners in Health have used to strengthen. You get money for a particular cause, but you use it to strengthen the healthcare system. So in thinking about, say, non-communicable diseases, there's going to be money that's used in the screening of various of these conditions. There's money for the screening, there's money for prevention, and then when it comes to people seeking care, how do you strengthen, say, the district hospital, or kind of the entry points, which we are going to be seeing the patients who are coming in with non-communicable diseases, and then empower them to be able to take care of these patients. Thinking about anything from blood pressure monitoring, effective treatment for high blood pressure, and then just simple cardiac ultrasound echocardiography to screen people who have valve disease, people who have high blood pressure, and are developing heart failure. So it's a major burden, and so now it's a time to start thinking about the healthcare system, which really was primed to deal with infectious diseases. But if you think about cancer, I dwell a little bit on cardiovascular disease as part of non-communicable diseases, breast cancer, cervical cancer, affecting lots of young women in sub-Saharan Africa. So we have to start thinking about ways in which we can strengthen the healthcare system, educate and sensitize the population, and then figure out ways to, deal with both the preventive side, but then also the management of these illnesses.
And hopefully there will be synergies, the chronic disease of HIV, the chronic disease of heart failure.
Correct.
There are important differences, but when it comes to community outreach, a sick grandmother, a sick father, a sick uncle, I think that's what the community understands. And there are important clinical differences, but that border between sick and well, that's something that everyone understands more viscerally. And the ability for a group like Lwala to reach out, connect people to care, and also address some of the social determinants is very powerful. So I see great synergy in that, and I'm indebted to you as a cardiologist because I'm going to call you for all my most difficult cases. And so next steps for you, now you're off to Rwanda's next.
Yes, so heading out to Rwanda, I'm doing this interesting new fellowship that Brigham and Women's Hospital has established, the Division of Cardiovascular Diseases and Global Health Equity, where they've created a fellowship. As a fellow, I'll be spending close to 10 months abroad. I'm going to be working with nurses in 3 sub-Saharan nations, so going to Rwanda, then Malawi, and finishing up with Liberia. And the goal is to train the nurses in basic cardiac ultrasound skills. So have them trained and be facile enough to be able to diagnose valve disease, but then also heart failure, and then figure out ways to manage those conditions. Who are the patients who need to be referred for cardiac surgery, and who are the patients who just need to have their medications changed one way or another. And the goal is to use this model to train nurses who are in the district hospital level. So more of a decentralized system instead of focusing on, the bigger referral healthcare facilities. And the goal is, with success in these countries, then we can roll it out among other nations. And, just like you mentioned, the partnerships with various organizations who are already doing work with community health workers, strong outreach to the community. How can we strengthen and equip them to leverage those synergies that we already have had in battling infectious diseases to use this for non-communicable diseases?
Wonderful. Well, as you proceed on this adventure, we hope that we continue to get reports from the field on how things are going. Lwala is lucky to have you. The good people at the Brigham are lucky to have you, and I'm indebted that you spent an hour before you fly out this Sunday to talk to us in this roundtable discussion. Any final parting thoughts?
Yeah, it's been a wonderful opportunity. Thanks for chatting and hearing a little bit about what we are doing in Lwala. I'm indebted to my parents. I'm indebted to the people of Lwala, who've always been such strong supporters, and then to the global village that has really adopted us and come alongside us to support and dream with us. And with their support and help, we have done some amazing things. And the folks who are working on the ground in Lwala, they're working day in, day out, and strengthening the community. And like I said, when you reach a point where the community members are they're excited about doing things for their neighbors, it's a great moment for community. So, as they say in Swahili, asante sana. Thank you very much.
Asante sana.